short video. I'm gonna briefly talk about point of care ultrasound, or POCUS. It's gonna be really about basics. It's gonna be on like introductory video. I'm gonna go over the stuff that you probably want to know about before you start hands-on experience or learning about POCUS. So hopefully you will find it useful. So let's start. This is how most of the ultrasound machines work. You have the ultrasound machine itself, you have the probe. The machine sends electricity to the probe converts it into ultrasound waves and send it to the subject, and then part of these waves will go back to the probe, and then the probe will receive it and convert it back to electricity, and that will go to the machine, which will be displayed as a black and white picture. So most of the machines, they actually use piezoelectric elements or piezoelectric crystals, and these are the kind of the basic elements in these devices, most of the handheld devices that we have, like the V-scan, the Clarius, and the Lumicity. Now the butterfly uses a different mechanism, totally different mechanism. It doesn't have the device doesn't have the piezoelectric elements or crystals. It actually has a chip, and this is probably one of the reasons why the device is cheaper than the other devices, and also per the manufacturer, it's probably more stronger, meaning if the probe fell to the ground, it's more likely to not to be damaged compared to the other devices. So most of the traditional ultrasound machines, they have many probes that you need to change if you want to change your examination. So for example, there's this linear probe or high frequency probe, which you can use for procedures, which you can also use for like examination of skin and soft tissues. If you're looking at the lungs also, you can use this one. And then there is these two low frequency probes, including the curvilinear probe, which is also called the abdominal probe, and you can use this one for examination of the abdominal structures, and the cardiac probe, or the phased array probe, which we use for cardiac examination. The intracavitary probe, we don't use that much in internal medicine. So another cool feature about the butterfly is that it actually has all these probes in one device. So you can easily change your examination from the high frequency exam to low frequency exam just by pressing a button, and that really makes it much quicker than the other devices. So another important principle that I want you to be aware of is called the acoustic impedance. It's basically how much the structure of the organ under examination, what's its capability of reflecting the ultrasound waves. So for example, for fluids like blood, as you can see, most of the ultrasound beams received by blood vessels would actually be bypassed. It's not going to be reflected at all, or to the most part, and this is you can call this a structure anechoic view, or anechoic structure if you want to be fancy. So that's why the blood vessels appear black, and you guys probably have seen that when you're doing like central lines or other procedures. And then for other soft tissues, for example like the liver, it reflects some of the ultrasound beams and bypass others. So that's why it's appear like gray, and that's called isoechoic. And then anything in between the anechoic and isoechoic is called like hypoechoic structure. This is kind of the ultrasound language. And then other structures like the diaphragm, for example, it will appear brighter than the liver, and that's because it tends to reflect back to the ultrasound machine more ultrasound beams, and very little ultrasound beams get absorbed or not sent back. So that's why it's a bit brighter, as you can see here. And then the probably anything with calcium in it, like the bone or stones, these are actually they reflect most, if not all, of the ultrasound beams, and that's why they appear really very bright and white. And this is called hyperechoic phenomenon or hyperechoic structure. And this includes both, but of course bone and stone is more hyperechoic than the diaphragm, for example. Now we're going to get into the ultrasound modes. We're going to just go briefly about over the modes that you most likely going to encounter. The most common one and the traditional one and the default one is the two-dimensional mode, or the 2D mode, or some people call it the B mode. B for brightness, or bright dots, because it's basically formed by little dots, black and white dots, which is the way that the ultrasound machine interprets the wave that's coming from the structure. And in this picture you can classically see what the definitions that I was talking about in the previous slide: the hyperechoic, isoechoic, anechoic, or hyperechoic structures seen in this 2D mode, or the B mode. So the second most common mode that you're probably going to use in the medical world is motion mode, or the M mode, which is basically another way of looking at the structures, but this time in the time axis. So for example, if you are doing the 2D mode of the heart, or like cardiac exam here, and then you decided to look at it using the M mode. This is here's the probe where the arrow is, and then you press on the M mode, and then a line is gonna go all the way from the probe all the way down to the bottom of the image. And then basically what happens is as if you're like really cutting the image of the structure along this line, and then look at the image from the inside. So in this image, for example, here is going to be the chest wall, because it's the most closer to the probe. And then as you go deeper, you're gonna see the right ventricular cavity, and then the septum, and then the left ventricular cavity, and then the posterior left ventricular wall, going from superficial to deep. So for example, here you can you can tell if this is like if this is like a systole or diastole cycle, right? So you see the contractility here during systole, and here during diastole, systole, diastole, and so on. And these images, each particular disease has specific characteristic on this M mode. Most of the time, for the most common practice that you might need it for is actually when you're doing the IVC examination, because you want to measure the diameter during inspiration and during expiration. So the M mode will be very useful, and also it's useful to look at it when you're doing lung examination, as we're gonna see maybe in other videos. So the third common mode that you're gonna encounter is the Doppler mode. And to understand the Doppler mode, there is the principle of the Doppler shift. If you really understand the Doppler shift notion, you can really understand the Doppler mode really well. So basically, here, for example, we have this structure here. It's static, it's not moving, and when that happens, the probe, the ultrasound probe here, is really gonna perceive that object in a certain way without changing the frequency. Now what happens if, for example, the object is actually moving towards the probe? What's going to happen is the frequency of the ultrasound waves is going to be perceived by the probe as high frequency waves, and that's compared to, for example, if the structure is moving away, you know, from the probe, from the ultrasound machine or from the ultrasound probe, the probe is going to perceive the waves coming from that moving structure, which is moving away, as a low frequency waves. And that's really important because, as we said before, is the way the probe perceives the ultrasound waves is how it interpreted the images after you operate the machine. So keep that in mind. The change in frequency depending on whether the object is moving towards or away, you know, from the ultrasound probe. Now this is kind of similar in a way, one way or another, to like when you really in the street and then from distance you hear the ambulance coming in, and then it, you know, bypasses you and then it goes far away. You know, the quality of sound that you hear when that happens is basically kind of a similar principle to the Doppler shift. The way that you perceive the sound of the siren is really different when the ambulance is moving towards you rather than when it's moving away from you. So you know, when you're using the probe for the for your device, the probe will really perceive this change better when it's in the same line with a moving subject, like, you know, 180 degree. Now what happens if you look at the structure from a different view, meaning you're looking perpendicular, like 90 degrees from top to bottom. Now you're still gonna have some wave of ultrasound coming to the probe, but, you know, as you can imagine, it's not gonna be as strong as a wave that's gonna be perceived when the probe was at the 180 degree. So the best to perceive this change in motion is better done when the probe is 180 degree or in line with the moving structure, and that moving structure most of the time will be blood, right? So this is when we use the Doppler shift principle more often. Having said that, people have used the Doppler shift to create different images, and the most famous one maybe is the color flow Doppler, the one here. So basically, so this one again uses the principle of the Doppler shift, and traditionally they decided to make it in a way that the waves that are coming to with high frequency coming towards the probe is going to be red, and the other low frequency waves coming from a moving subject that's moving away from the probe is going to be reflected by a blue color. This is just traditionally put, right? But the principle is kind of the same, and some people use BART to kind of remember this. So blue away, red is towards the probe. Another use of the Doppler shift is to create what is known as the Spectral Doppler. This image here, you probably have seen this when you saw some of the echo images, right? So basically it's the same principle. So conventionally they decided that, you know, anything above that line here basically represents high frequency waves that is coming from object that is moving towards the probe, and anything below that line represents the low frequency waves that are coming from an object that's moving away from the ultrasound probe. So it's kind of, instead of the red and blue, it's created in a vertical line across the time again. So this mode actually is just added recently to the butterfly. It's most useful when you're doing an echo, as we will see in the next slide. So to be honest with you, in the common POCUS exam that you're probably going to do, this one is not really, you might not feel comfortable doing it, and it really needs some experience. I personally don't usually do it in my cardiac exam. I just rely on the full report of the echo if I will order an echo in my patients. But it's really nice to know, and it will really help you understand exactly what the cardiologists say when they are talking about diastolic dysfunction and pseudo normalization and delayed relaxation, which both suggest diastolic dysfunction, because systolic function can easily be seen by POCUS, right? You can easily appreciate the contractility. Diastolic is a little bit tricky. There are many ways to report that, but this is one way that people has used the spectral Doppler to as one way to estimate the diastolic function. So basically, when you are in the M mode, for example, here in this image, you press on the spectral mode, spectral Doppler mode. Basically, what's going to happen, again, just like the M mode, there will be like a line that you can move. And then, for example, in this case, when you put the line here, you're telling the device, you want to look at the motion across this line, which will be here in this case, across the mitral valve, right? So basically what happens when blood during diastole, blood will flow this way from the left atrium to the left ventricle. So again, anything that's going to be reflected by the E here. And then there's another A wave, and this is basically the other movement that's happening from the atrium towards the ventricle due to the atrial kick, right? So as you can imagine, the E wave is much larger than the A wave, because diastole, the flow is larger at the beginning of diastole compared to the 30% kick that's created by the atrial contraction. So what happens when you have left ventricular hypertrophy or constricted pericarditis, anything that delays or impairs the relaxation, then as you can imagine, during the atrial kick here, the atrium has to create higher force to move the blood over this stiff ventricle. So the E will be greater than the E, and this could be an indicator that there's probably a delayed relaxation, as sometimes been reported. And when there's more stiffness in the left ventricle, again, what happens, the left atrium will compensate, and the atrial kick again will be less forceful, and that will create an image that kind of looks like the one at the beginning here, right? So this is called pseudo normalization, because the E and the A wave, they're looking similar to a normal left ventricle, but actually it's not because of that, but because of the compensation that the left atrium was able to create. So this is just something to keep in mind. It's always nice to know, but to be honest, during the internal medicine wards, you're less likely will need that. But unless you really want to practice it, feel free to do it. So another important principle is the principle of gain or resolution. So the function of gain in the butterfly is actually very easy. So you just need to slide your finger on the screen, right or left. So it's really very straightforward. So gain is basically how bright or dim the image is. So for example, in this first image here, as you can see, it's really most of the structure are really dark, so you can't really tell exactly this, where is the Morgan's blood vessel, is this here is another blood vessel or not. It's not very clear, and this is because the gain is low. And then for the other image, is actually in the other way around. It's actually too bright, right? So you can see it's too white, and this can also be problematic because, as you can see here, I'm not sure if there's any, thrombus. Maybe there's something inside the vessel. I'm not too sure. So that also can create a lot of artifact that can make the image not really optimized. So the one in the middle, as you can tell, is probably the best gain or the best resolution, because you can tell the vessel here clearly, and it's not like overgained or undergained. So this you learn that by practice as you do more and more images, but it still is straightforward. The same thing for depth. So basically, you can increase or decrease the depth by sliding your finger in the your device, your iPad or your cell phone. When you're using the butterfly, just move your slide your finger up and down. So it's very intuitive, very user-friendly. So really, if you want to look at the deep structure, you just go deeper. If you want to look at superficial structure, go shallower, and the machine will adjust the gain accordingly, because the gain will change as you look at the deeper structures versus, for example, superficial structures. So basically, for this cardiac image, for example, this is too shallow, so I can't really see the descending aorta really well compared to this one here. And if you're like really too deep, this is also not good, because there's a lot of structure that you can't really see well, and it's not really optimized. So the device will, most of the time when you use when you pick up your examination, it will adjust the depths, the appropriate depths, but you need to adjust it even more as you're doing the examination. So another important principle is orientation. This one is actually simple. So there's always a marker in the top corner of the screen, either right or left, depending on your machine, and that corresponds to the marker that you always see in the probe of your device. So basically, this is just really to tell you, to give you like orientation about your image, and where is it exactly in the space. So for example, here in this image here, if you really want to go a little bit to the right, because you want to see if there's any like a structure here or something that that you have to move the probe in this direction to get to that structure. So if you're for any reason you have the probe in the other way around, so and you want to move into this same direction, you're gonna see the image moving into the other direction because the orientation is not right. So keep that in mind. Conventionally, for most of the examination, I would probably say all except one, maybe, the marker of the probe and the marker in the screen, it's usually the one in the screen is usually on the top left. But for some reasons, I don't know, someone just decided that probably we should make the cardiac view here a little bit different, and let's just make it to the left. I don't know why, just conventionally. Cardiologists are special, I guess. But anyways, it's just keep that in mind when you're doing your exam. Always try to look at where your marker in the probe is and where the marker in the screen to be in the right orientation. So this one is simple as well. There's four basic transducer movements. This is created and they were named just to have a common language, so that sonographers, when they're talking and when they're like describing things to each other, they know what they're talking about. So sliding is basically moving the whole probe up or down, right or left. It's usually done when you're like really trying to find the best view or window. So usually at the beginning of your scanning, you use it quite often. You're just looking around and around, sliding right and left, up and down, until you get to the window that can get you to the structure better. And then rotating, as you can see, is really just rotatory movement of the probe. If you really wanna, the classic one, for example, if you're looking at the the heart in the long axis, then you want to cut it into the short axis. You rotate it to the left 90 degrees, and then it will go this way. So this is rotating. And then another common one is tilting, and it's also called fanning. So for example, here you're fanning to the left, and here you're fanning to the right, or depending if the patient is in this side, then probably this is you're gonna tell the one who's doing the exam, fan to the patient right or fan to the patient left, to get to get to see another structure. This is called tilting or fanning. And then the last one is rocking, which is basically similar to tilting, but you're really moving the probe into the other longitudinal axis. And it's also done to, if you want to like scan a structure or something, like the kidney or something, throughout its length. So these are the basic four transducer movements. So in line with talking about the transducer movement, I want to bring an important note here. So while you're moving your probe or transducer, try your best to get the probe perpendicular to the object that you're looking at, like these two probes here. This is really the position that's most likely is going to get you the best quality compared to this one here or this one here. So really the main goal maybe of the moving the transducer is really to try your best to get the ultrasound beams perpendicular to the object that you're looking at or the tissue that you're looking at, to optimize the quality of your image. So one nice thing about artifacts in ultrasound is that actually compared to MRI or CT scan, the artifacts are problematic, right? But in ultrasound, actually, it's very useful. A lot of times, the normal versus the abnormal or the pathology is most of the time created by the artifacts. So artifacts basically is just like, because of the way that the tissue reflects the ultrasound beams, depending on their acoustic impedance, like we talked about before, and the way that they scatter these waves really creates some artifacts in some or most of the ultrasound examinations. So for example, here in this lung view, you can see there's these lines, this hyperechoic lines, is called the A lines. A lines. So these A lines actually, you're gonna see them during a normal lung examination, and then there's other artifacts that sometimes you might see in, for example, someone with cardiogenic pulmonary edema, which will be in the different direction of the A lines. Is actually going to be from top to bottom like this. It's called the B lines. So all this A lines, B lines, and other artifacts in ultrasound, they're actually very useful, and we use them to talk about normality and the pathophysiology. So one thing I want to add is that among all the tissues, the one that's usually done really like is air. Air is classically described as the enemy of ultrasound because air tends to scatter the ultrasound beams all over the place. But again, that will create some artifacts that can be actually useful in some examinations. So artifacts is actually your friend in ultrasound. So when it comes to billing, I don't think it's really very important at this point, because I think it's something that we maybe think about in the future when people are more familiar and they're more comfortable with using the ultrasound or POCUS. But something to be aware of, you actually can bill for your limited ultrasound examination. In the inpatient, in the outpatient, wherever you do it, using your device, using the hospital device. Of course, there will be like some change in the coding and billing if you're using your own device versus not using your device. But anyways, there are certain requirements that you need to fulfill to be able to bill for your exam. So of course, basic data is always there: the patient name, age, gender, MRI, date of birth, time and date of your exam, and then what's the indication, why you're doing the examination. For example, assess the volume status in patient was possible dehydration, and then you describe what you're seeing. Is this like a complete exam of the IVC or complete cardiac exam or limited cardiac exam? And then what are your findings? This image shows, or the video shows, an IVC of 2 centimeters that collapses more than 50%, for example, which might indicate dehydration. This is kind of your impression. And then, of course, it's very important that you make sure that your image is actually stored somewhere, so that in the future, if anyone wants to review the image, it's available in the electronic health record. Alright, so some good news. There's actually a lot of resources that you guys can utilize when you start learning about POCUS or bedside ultrasound. In addition to the free videos in Google or YouTube, there's other educational resources that's also available for you. For example, Access Medicine, you have free access to that. They launched this new book a few months ago about pocket guide to POCUS. It's actually very nice, very good material, a lot of videos and images as well. Also the ACB, they also has a lot of CME modules about point of care ultrasound, and is also free for members. And Butterfly, they actually did a good job creating a lot of short clips or videos for many really POCUS examinations, and these are actually available in their website when you log in, or I think it's also available in your device. So you can always look at those when you're doing your examination. For those who are really interested in point of care ultrasound, this book is actually really nice. I think they launched the second edition. I had the first one. It was much cheaper. It was $20 or so, but now I think it's about $80. But it has online version, so you can have a lot of videos that you can see, and images as well, in addition to the hard copy if you want. So I'm sure there are many others, but these are the ones that I really found very useful. Alright, so we came to the end. I really hope that you guys get some benefit out of this video. We touched base the ultrasound knobology really quick. Knobology is basically a fancy word for how to deal with the ultrasound keys and knobs, which is actually made much easier nowadays because of the new devices. We talked about the different types of probes. We talked about the principle of acoustic impedance. We talked about some of the basic ultrasound modes. We went through the gain and what it is, the depths, orientation, and then really just quickly on the artifacts and how useful they are in ultrasound. Just a note about the billing, looking into the future, and also some resources that can help anyone who wants to get better on the the ultrasound. But of course, the most important thing is really practice, and practice. So I hope I'm gonna see you in other future educational videos, and have a good and nice rest of the day. Bye bye.